Today, we're going to be talking about life-threatening asthma and how the emergency management of it, particularly when it comes to kind of transporting the patient from a community hospital or an outside hospital in general to the ICU, and the considerations that we, especially, as a fellow who is working with you all over the phone until you enter our unit, the things that I kind of think about with that. So overall, we figured that today we'll talk a little bit about like what exactly the pathophysiology behind an asthma exacerbation. So what exactly is happening, and then the management that we think about, and you all definitely know so well with regards to how to manage those patients with critical asthma. And then at what point do we consider intubating, and what we kind of think about when we are intubating those patients and how to prepare those, because I think that is the biggest thing in terms of making sure that these patients who are so sick, and a lot of people are very hesitant to intubate, that we can ensure success. And then how do we go about managing the ventilator and the complications we see afterwards, that are considerations that we all should be having. So this is a patient actually that some of you this is a common case, but is based on a patient that I took care of with you all last year, who was transported to our unit. So this was a 4-year-old with a history of asthma. He came to an outside hospital with a 1-day history of wheeze. In terms of thinking about exactly what is happening with asthma, I guess, what are you all seeing on this, this like patient who this is what they see in the emergency room?
Retractions and impressive retractions.
Yeah, exactly. So excessive retractions, like belly breathing, is, I feel, a lot of the times what people are saying, seesaw breathing. So we're seeing our intercostal muscles, and then we're also seeing like this forced exhalation almost, where you're spending more time trying to like exhale and using all your muscles really in that exhalation phase more than really in the inspiration. And that really is the basis of what we think about with asthma. And so when we have our normal airways, if they're nice, wide open, patent, and then at baseline, because of all this remodeling that happens in children with asthma, their airway walls are just a little bit thicker to begin with. And then as soon as they have some sort of trigger, whether that's a viral illness or, an environmental trigger or anything of that sort, their airway narrows even more, and because of all the inflammation and thickening. And so they have all of this resistance, particularly when it comes to breathing out, because their airway will collapse. And so and they have this dynamic collapse, and that leads to air trapping, and exactly what we're seeing with this forced exhalation and that work of breathing that you all saw too. And so similarly, this is kind of showing that as well. There's no audio on this, but that inflammation and how hyperreactive those airways are lead to this dynamic kind of the swelling and this dynamic bronchospasm. And, adding mucus to the picture also ends up kind of leading to kind of this increased area resistance that we see, and it a lot of times isn't responsive to any sort of treatments that we see. And like I was saying before, they are at baseline have that remodeling, and so some sort of trigger can only make that worse. But when we think about inspiration, actually, there's not much of a difference compared to all the other patients or you or I. But the bigger issue comes when you're trying to exhale and you're really kind of, you have all this air trapping. And then because of the way, and we'll get to this in a few slides, but the way that like you're trying to exhale over with this airway resistance ends up leading to collapse of the airway. And then you just end up having kind of this like really long exhalation and low flow, and you kind of see them doing that. And then leads to this like scooping pattern that we kind of mentioned, we discussed, and they never actually truly exhale all of what they inhaled. And so it leads to that air trapping and like that kind of hyper expansion and hyperinflation that we see on our x-rays for these patients. And so going back to our case, on the initial call, when they give you the vitals, they tell you that this patient has a heart rate of 140. Their blood pressure is 100/73. So for a 4-year-old is a little bit high, but okay. Respiratory rate is 48. Our SATs are 88% in room air. Just like we said, he had retractions, was speaking a few words. And then when they listened, they said it was pretty tight, but they heard a wheeze here and there. They got a few labs at the outside hospital, showed a white count of 12, K was at 3.3, and their glucose was 253. The chest x-ray showed just some hyperinflation and peribronchial cuffing. And then because this was last year, we made sure that we checked their COVID and our COVID, RSV, and flu, and it was negative. They have already given a duoneb twice, and then also have given albuterol on top of that, and gave prednisolone. So if you all got this call, what would you want to do?
I'd ask them to give MAG.
Give MAG, okay, perfect.
Yep, and around.
More albuterol.
More
Or
albuterol.
albuterol. Yeah,
Give to begin with.
Yeah, what was the baseline?
Yeah.
How much were they getting for their albuterol doses?
they were giving 2.5 milligrams.
Oh, no.
More.
they
Yeah.
More.
Much.
More, exactly. Exactly. Anything else that you all could think of?
If they have access, they could give IMFE if they felt like they needed to be able to open up quickly.
Yeah.
And get
And you said IM epi, so you don't even really need access for that, right? Like you could just give it IM.
and then give MAG.
Like MAG, perfect. Any other thoughts?
And a bolus.
And a bolus, for sure. What about their respiratory support? Anything, or you just let them kind of like,
That's her 88%, which means she's like kind of far down that line because she's not spatting as well as probably not ventilating, so.
yeah.
It would be great if they started BiPAP, but none of our outside facilities.
Exactly. No, totally.
I think she needs BiPAP,
Yeah.
but I'm disagreeing.
But if they don't have BiPAP,
Keep it on the
High
mat.
flow underneath.
Yeah, some high flow under it, yeah.
With the albuterol.
I wouldn't do a high flow. I feel like once you've gone high flow, they stop paying attention to the albuterol.
yeah. Yeah.
Make sure they're giving oxygen with the albuterol.
Yeah.
Sometimes they air instead of oxygen.
When we get these calls, a lot of times they end up being on high flow, but exactly, I think that a lot of times, and then there's like some data actually that says that like when you are on high flow, the albuterol doesn't actually like, it doesn't allow you to deliver albuterol that well, depending on the type of high flow setup that they're using. So it's an interesting thing, but I do think that like, you know, you want them to do something until you all get there. And I think that at the end of the day also, right, like making sure we rescue this child is like a big thing too, to get them to a place where they can get the therapies they need, including BiPAP. So I think I agree with all of the things that you all said. So you get there and then you see that, and we'll talk more about the therapies in a second, in a little bit more detail, but you all send out a team, and when you get there, you have, heart rate of 155, blood pressure is 115/60. The SATs are 94% on 65. This place is actually lucky enough to have BiPAP, so they put them on BiPAP 14/6. Respiratory rate is 42. The patient is agitated, grunting, severely retracting, nasal flaring. In addition, based on your recommendations, they gave continuous albuterol nebs. Are they're on continuous albuterol through a nebulizer, have given a normal saline bolus followed by IV MAG, and then they also gave a dose of IM epi. But now, given what you're seeing, what would you want to do?
More epi.
More epi?
Maybe some turf.
Maybe turf, yeah.
Yeah, 100%. And how would you give that turb?
You gotta give a loading dose and then
And then start to do it.
Yeah, awesome. What else? Is there anything else that you all could consider?
I mean, you try to go up on the BiPAP settings, you're already fairly high. I would be concerned about mental status.
Yeah,
She agitated because she's like in oxygen air country, or is she agitated when BiPAP and they haven't chilled her out enough for it to work, right?
yeah, exactly. I think those are like exactly the considerations that I also would have with this patient, and also the things that I would consider doing. So first and foremost, when we come with like managing patients in terms of thinking about actual like respiratory support we give, but all of you said like jumping on like exactly BiPAP. And in theory, I think some people do practice with saying that, based on age, that they give different amounts of BiPAP, but you definitely could have room to go up on the BiPAP. You can, especially because people are a little bit more nervous about intubating asthmatics, for which the reason that we'll get to in a little bit, going up on those pressures, you're on 14/6, going up to 16/8 or 18/10, it's not optimal, but doing what you need to do to kind of help pop open your airway and try to get a little bit more improved ventilation, just like you all said. High flow nasal cannula for kids who are a little bit younger can be helpful, but I usually think like under the age of 2, which is like where it's like a little bit more of that like bronchiolitis picture or like an asthmalitis picture, if you will, can be helpful, especially because it's a little bit better tolerated. But unfortunately, the flows that you need to get that pressure to help on the like in the way that BiPAP and CPAP work, it would be like way too much, and they like very poorly tolerated. And then the other thing, like I mentioned before, is that some of the setups that we have, don't actually allow for good delivery of your albuterol. And then sometimes, in the ED, they're super busy. And so like, well, they just put them on albuterol and then not actually give like the Q2 puffs, to be able to continue to give them the bronchodilator that they actually need is 100%, like definitely a consideration to have. And then for kiddos that are not actually working as hard, we can think about like a nasal cannula or using the aerosol mask to just have some oxygen delivery, but from the VQ mismatching that you can have with being on continuous albuterol. I think Michaela just joined.
Hi, everyone. Sorry I'm late. I'm late.
No problem. Thank you for joining. So these are kind of as you all mentioned already, kind of the different setups that we have, but in this patient who's obviously is working pretty hard, we're worried about the mental status, we're worried about the ventilation status, despite getting a lot of different therapies that I think, as you all said, BiPAP is the way to go. And a lot of people, if they don't have, a lot of places don't have BiPAP at the outside hospital in their EDs. And so, but I know you all bring that with you. And so I think that's amazing. And definitely a therapy that they will benefit from. In terms of the medications, you all hit a lot of the medications as well. And a lot of these, obviously, we have in the ICU that maybe or some of them, particularly aminophylline, that you won't have in transport, but just helpful to know that that's another medication that we use. First and foremost, from obviously the biggest and best treatment for the airway inflammation is steroids, but it does take some time for it to work. And a lot of times at the outside, they'll give, dexamethasone or prednisolone. And so what we always recommend is switching over to methylpred. Even though there's like some evidence to say that there's actually not too much of a difference, but it's IV, we know we can dose it a little bit more frequently. And typically we give the first dose of 2 mg per kg of like a bolus dose, and followed by every 6 hours, we give 1 mg per kg in the ICU setting of methylpred. But knowing that this can cause some of that hypertension, hyperglycemia, and in theory can lead to infection. But that's less of a concern that we have when we're, obviously in the acute phase. Beta agonists, as you all mentioned, continuous albuterol, and kind of, we have our doses. You can do 5, 15, 20, and, a lot of that's based on age, but trying to increase our dose to kind of give albuterol. And then, as you also mentioned, terbutaline, giving that bolus dose and starting an infusion. They don't have access. Sub-Q terbutaline is, and you can give it at IM as well, but there are ways to give bolus doses of that, and still, it still has quite a good effect, particularly when these patients are so tight and they're not really getting the continuous albuterol inhaled because they're so bronchospastic. Giving them something IV can be really helpful to allow for that bronchodilation. And as you all mentioned, IM epi can also be helpful in that way. That being said, a lot of patients, and I'm sure you all have seen this as well, can get really tremulous and tachycardic with the beta agonists. And because the way that it works is it also pushes potassium into your cells, they can have some hypokalemia associated with it. And then the other big thing to think about is that it can also cause some dysrhythmia. And so we've seen patients who have gone into, SVT from like the degree of beta agonists that they're on. So definitely something, and like can be very, very, very tachycardic. And so definitely something to think about with these patients. And they can also have like ST segment elevation, particularly with terbutaline that we see. And so just something to keep in mind. They can also have some diastolic hypotension. As you all mentioned, magnesium is a great medication to help with that bronchodilation, and it works by smooth muscle relaxation. But the thing is that it works everywhere, so can lead to some hypotension. So you all mentioned a bolus as well, and so making sure to give that bolus. You can also have some like nausea, vomiting, arrhythmias, and some weakness associated with it, but we don't see that too often. And then knowing if we're giving a lot of magnesium, we should keep an eye on our electrolytes. Trivent or inhaled ipratropium bromide, a lot of times we see that combined with albuterol as a duonab. And I think the one thing that is just important to know about that is it can cause fixed and dilated pupils. And I've had patients that we come in, we're like, oh no, like, is there something going on intracranially or in their head? But it's just because they got Atrovent. And so that's something that I always, like a little pearl that I always like to remember. IV amylophenol, I know like we don't usually carry on transport, but is can be a really helpful medication that we use, but does have a really narrow therapeutic window. And so we use levels to watch it really closely, but can cause some nausea and vomiting as well. And then another medication that you all have, and we know that you all use as well, is ketamine, both as like a bolus dose, and then we in the ICU we tend to use it as a drip as well. And so, giving a bolus dose of, it can be it works as a dissociative anesthetic, but also can really be nice for bronchodilation. So like to, keep the mask on, but also to kind of allow for that bronchodilation, but can cause, some increased sialorrhea, or like they can drool a little bit more. With pushing it, you can have laryngospasm. So just something that we have to keep in mind. And then particularly in our like school age and older children, it can lead to some like pretty gnarly emergence delirium. And so sometimes giving a little bit of midazolam with that can be helpful, just because they can feel really, really out of it. And like it almost like backfires in the way that we're trying to use it for. Typically the doses that we like for, mass tolerance, but also for that bronchodilation, it's helpful. You can give it in like 0.5 to 1 milligram per kilogram doses, but can be given up to 2 if like we're really in a spot where we're really trying to break bronchospasm. Which medications do you feel like you all use the most commonly when you're like in route?
Exactly, that's a throwback one.
Yeah, I feel like MAG is like what I hear a lot about, and then like the TERB boluses as well. Obviously in addition to like steroids and albuterol and those kinds of things. But I guess the biggest thing is, as you all mentioned, like what do we have to think about when we're considering intubating? And so you all mentioned altered mental status already. And so that is a sign that we're just like not ventilating appropriately, that, our PCO2, you're not exhaling your PCO2 might be a little bit higher than you expected. And so that is a huge reason, like when they're obtunded, to think about, oh, like this BiPAP is not working. We need to figure out something else to do. And then, if they're continuing, you do all of these different maneuvers and therapies, and they continue to have a low SAT and have refractory hypoxemia. Sometimes though, like as you all know, like when we give some of these bronchodilators, they may briefly have some hypoxemia from that VQ mismatching or that ventilation perfusion mismatch that happens right after we give them. But if it's refractory, it's really not getting any better. If you're on maximal therapies, to consider hypoxemia. And then of course, in the patients that have arrested, either from, cardiac arrest, respiratory arrest, those are all patients that a lot of times at the outside, they will have already kind of moved to intubate at that point. But if you encounter this en route as well, it's definitely something those are the patients that we think about intubating. So when you all think about, if you all have intubated patients for asthma, what do you all think about when it comes to like how to prepare those patients for intubation?
I think,
What sedation?
yeah. I like ketamine sedation for these kids, and I would definitely prep my emergency meds
100%, yeah.
prior to intubating. And I found it very difficult to get them on a ventilator.
Yes.
Yeah.
Extremely. I was not successful getting them on a ventilator. We got it.
What do you mean by like what was particularly difficult?
Every time we got them on the ventilator, I think we just destatted. I don't think we were able to capture them on the vent.
Yeah.
And we had, bagging them didn't really fix this, but we had climbing CO2s. They continue to climb.
1/3.
Yeah.
Wow. Yeah.
30s, 40s.
Monitor cuts off at
that's-
148, just for the record.
Yeah.
Trying to find a way to ventilate them.
Yeah.
is hard because it's already like hyper expanded and bronchospasming and all the other things going on, so.
We did manual exhalation.
Yeah, many, yeah,
Pushing
we
on their
a
chest.
lot of manual exhalation, but we were
Yeah,
never.
100%. Yeah. Exactly. And so I think you all hit on a really important point is that like you may get the tube in, but then after the tube is in, how like managing the vent and like kind of now making up for like what they were doing on their own is really challenging. And so I think that management is part of the reason that intubating these patients is so tricky in the first place. In addition to that, I think the other things to think about are, as you mentioned, having emergency beds ready, because as we move, the big things that I get nervous about when we think about intubating a patient with asthma and in status asthmaticus is that you're moving from this negative pressure ventilation to positive pressure ventilation. And so you like are increasing the pressure inside your thorax or your intrathoracic pressure. And with that, you're going to decrease your venous, like your blood return to the heart or your venous return. And that also sets up a patient who's already probably a little bit acidotic from their, poor ventilation for, high risk cardiac arrest and really poor outcomes from that perspective. So when we think about like actually preparing an intubation patient for intubation, trying to pre-oxygenate as much as possible. You're probably already at that point on 100%, and if not, putting them on 100% FiO2 while you prepare those medications, as you mentioned. One of the biggest medications that actually is helpful is giving them a bolus right before to kind of pump up their preload and pump up their kind of their intravascular volume so that when you switch over from that negative pressure ventilation to positive pressure and increase that pressure in their chest, they're able to still fill their heart. And then, as you mentioned, also making sure you have those vasoactive medications ready. A lot of times we'll intubate on some epinephrine, like put them on an epinephrine infusion at like 0.03, 0.05, and then intubate on that. But having co-doses of medications, including epinephrine, sodium, or bicarb, calcium, are all obviously also very important to have ready because of all the changes that are going to happen in their hemodynamics. I think one of you had also mentioned sedation, and I think a lot of people will do this a lot of different ways, but, like we just talked about, ketamine is a beautiful bronchodilator. And so ketamine can be a really great medication to intubate with. And so this would be like the case, like I was saying before, where a 2 per kilo dose of IV ketamine can be helpful to induce, but also allow for bronchodilation, followed by some paralytic like rocuronium. And then in terms of other than medications, just equipment to have, making sure that we have a Zoll or an AED available just in the setting of, if we end up having a cardiac arrest, intubating this patient if we can on a backboard, just given that high concern for the hemodynamic compromise that could happen. And then in intubating, using a cuffed endotracheal tube and then just finding that largest size, appropriate size, just to make sure that we get adequate ventilation and don't have a leak, which would just make everything a little bit more challenging. Perfect. So that, in terms of thinking about the intubation, that's kind of the biggest things that I think about. Do you all have any questions or anything to add to kind of when you're thinking about intubating a patient? We'll talk about bed settings in a second. So thinking about our patient, so, he becomes super obtended. So you decide to make the decision to intubate. On intubation, you have a heart rate of 150, your blood pressure is 95/40, respiratory therapist is bagging, and you have a respiratory rate of 35. On 100% FiO2, your sat is about 94%. The patient is sedated and paralyzed. There is minimal aeration with this though, and you're really not even hearing a wheeze. The patient is still on continuous albuterol nebulized, and we gave another bolus. So at this point, kind of like what you had just all talked about, and thinking about ventilation, how do you think about like ventilating these patients?
A shorter eye time with a long,
Yeah, long expiratory phase for sure.
I tend to think about them having a much lower rate than we're accustomed to.
Mm-hmm. Exactly. What else do you all think about?
When setting the vent settings, having enough like pressure, what's the word I'm looking for, delta,
Yeah.
so they have space to exhale.
Yeah, exactly. Exactly. So I think the biggest thing like in these patients knowing is that they have this like dynamic airway trapping, like the air trapping. And so trying to do everything we can possible to allow them to exhale as far as possible to prevent further hyperinflation and that further air trapping. And so when we think about the different like modes of ventilation, I mean, when you are thinking about bagging, it kind of works the same exact way, but ultimately we want like a low I to E ratio. And so like a longer exhalation times or longer expiratory phase and kind of going for shorter I times. That being said, you don't want it to be too short that you're not able to actually oxygenate, but, and then aiming for higher PEEPs, which we'll get to in a second. And then when we think about PIP and like the peak inspiratory pressure, the thing to, make sure that we think about is that like ultimately, and, because of the amount of airway restriction that they have, the PIP actually, it's hard to say how much is like a good amount because their end airways, because of how obstructed that they are, may actually not see that pressure. And so really, ultimately, it's like the amount of inspiratory pressure that we need to be able to move the chest and to be able to kind of, like you said, bring our end titles down and kind of have better ventilation. And on our ventilators, we have ways of being able to kind of see exactly what we call plateau pressure or what their airways and alveoli are actually seeing. But the peak inspiratory pressure is just like kind of what their upper airway is seeing prior to the actual obstruction. Michaela, I don't know if you have anything you wanted to add to this part.
The only thing that I always talk about is we do a low I time, but it's relative to your breath cycle. So if you look at the I times listed, they're not actually that low, right? And you don't want to be ventilating on 0.6 especially in pressure control, because you're just not giving enough time for that breath to actually get into the patient. So when you think about a breath cycle for a patient that is breathing 10 times a minute, you really have 6 seconds. And so you need a decent I time and then about 75% of your time in exhalation, like Gayatri was saying.
Yeah. And then sometimes the other thing that we see, like typically, like, these patients, as you mentioned, as we talked about, for the intubation, they're sedated and we give them paralytic. And for transport, that's the safest thing to do for sure. Sometimes though, we don't paralyze these patients after the fact and we let them do like we were saying, they kind of can mediate their respiratory cycle a little bit better. And so sometimes we actually put these patients ultimately on CPAP pressure so they can also, kind of guide their own low respiratory rate in order to be able to ventilate. But that is like another mode other than PRDC and pressure control. A lot of the times our patients in their acute phase of illness will have in pressure control just so that we can kind of manipulate those pressures that we're giving them a little bit better and watch the volumes. But ultimately, a lot of them end up being in PRDC at the end. When we think about PEEP, there are like a few different ways that people manage PEEP. Ultimately, the big thing to like note for these patients who have air trapping is that they have this like high intrinsic PEEP. And so some people will choose to kind of set the PEEP of the ventilator or the PEEP that they're bagging at above what we assume to be their intrinsic PEEP. And so what the thought process behind that is that we can stent open the airways and really kind of overcome that intrinsic PEEP that they have to allow them to really be able to exhale and and be able to breathe out. And overcome or have like a differential between their upper airway and their lower airway to be able to exhale. And so the way that we actually measure their intrinsic PEEP is that we do an expiratory hold where we leave them in exhalation and then measure the PEEP that's on the ventilator. And then a lot of people will kind of set the vent PEEP a little bit above that. However, on the kind of flip side of that, some people also just kind of these patients are already exhaling against high pressures. And so some people will just leave the patient at a PEEP that is like kind of like our typical PEEPs that we think about or typically use 6, 8, 10. And then kind of try with different, we like do what we call a PEEP trial or kind of a PEEP PEEP grid in order to kind of try different PEEPs and see what actually ends up leading to the best ventilatory mechanics for these patients, what leads to the, best chest rise, but also exhalation, what leads to the best end tidal, and what leads to the best volumes, and kind of set a PEEP based on that. So there's two different kind of schools of thought on how we go about doing it, and there's not one right or wrong, just different styles. And so this just kind of highlights when we think about, what our airways are like when we are, we don't have, airway trapping. So when we inhale, ultimately, we generate a negative intrathoracic pressure, and that allows a pressure differential between our upper airways and our alveoli, and that allows for like air to flow in and for us to inhale. However, in someone who has an auto PEEP, for example, like these patients with asthma, their alveoli to begin with are already sitting at a higher pressure. And so then they have to actually generate this higher pressure to be able to inhale and to be able to, and then that pressure is kind of translated to their pleural pressure and ends up leading to needing to like overcome this higher pressure to be able to both inhale and use their active muscles. And then when it comes to exhalation on the flip side, because of the airway obstruction, the friction like causes a drop off in their pressures. And so that ends up actually leading to airway collapse, because when your pleural pressure is higher than your airway pressure, you end up having collapse. So this video actually kind of displays that pretty well. And so we can watch it. We do have a little bit of time to kind of go through that. And then we can also make sure that you all have this too, because I do think it's helpful to see on the other side, like afterwards, if you were, are interested.
Of course, in spontaneously breathing patient, you cannot do expiratory hold. You check for the auto beep. And usually, if you do that on the ventilator and you know the auto beep of, let's say here, 10 centimeters of water, the amount of extrinsic beep that you want to add to the circuit is somewhat between 70 to 80% of that auto beep. So if you have a patient on the ventilator, you can measure how much auto beep he has, and then you add, if it is 10 centimeters, you can add 7 or 8 centimeters of water to the circuit. But if the patient is spontaneously breathing, there is no way you can measure the auto beep, and at that time you just add the extrinsic beep gradually. You increase the value gradually, and you observe the work of the breath of the patient. By increasing the auto beep, you should expect by increasing the extrinsic beep, you should observe that the work of breath is decreasing for that patient as you go up on the extrinsic beep. Now, if you have esophageal monitor, you would be able to see the negative deflections or the excrusions the patient is doing. So this is the case where the PEEP is 0, and you see how much negative deflection. This is all the work of breath of the patient. So you can see how much the patient is actually exerting himself to generate that flow and inhale. Now, by adding PEEP of 10, you can see how these exclusions are decreased, and this means that the work of breath for this patient is decreased. I hope this explains how we benefit from adding extrinsic PEEP to patients who have dynamic hyperinflation syndrome and auto PEEP in relation to their work of breath. Thank you.
This video in general earlier on actually talks a little bit more about what I was saying before, which can just be helpful for review purposes of like why these patients work, this increased work of breathing. So we can definitely make sure that you all have access to this as well to be able to watch on your own time and to kind of review those things. Kind of reviewing exactly what I had mentioned before, when we think about the PIPs, I know one of you had mentioned kind of thinking about the delta P and making sure that we're getting in good, like using like high pressures to be able to allow for ventilation, and to kind of hit that home a little bit more. Just in terms of what we were saying is because of their high airway resistance, what you're bagging at and the peak pressure that you might see is actually very different than what they're actually seeing in like at the alveoli. And so when we're thinking about, are we going to cause barotrauma? Are we going to cause like a pneumothorax or something like that? A lot of the time, because of the amount of resistance that they have, they're actually not actually even seeing that pressure. And so what we can do on our ventilators is do an inspiratory hold, which basically what that does is holds them in inhalation and allows the flow that they're seeing to go to zero. And really at that 0 point is when we know what their end alveoli are actually seeing in terms of pressure. And a lot of the times in these kids who have severe asthma that we're intubating, they end up having a much lower plateau. So you might be, on a peak pressure of 35 or 40, but their plateau pressure and what their airways are actually seeing might be 18. And so that a lot of times we'll say like a peak to plateau, and that can be really helpful for us to know like the amount of airway resistance and the amount of actual obstruction that they're having. And make us feel a little bit better about using these high peak pressures initially, but it's something that's important to keep monitoring to know like, oh, is your asthma broken? Are we at the point where like actually they are starting to see some of this peak pressure, and are we getting to the point where we need to start weaning our peak pressures to not cause that barotrauma? And so when we think about blood gases, a lot of the times we are allowing for permissive hypercapnia, so that we don't have to like increase our settings, increase our pressures, because they are at risk of air leak and pneumothorax and things like that. And so we do tolerate a pH of like 7.0 to 7.2, and PCO2s can be as high as they honestly can be really, really high, and we're okay with that if their pH isn't, above 7. And sometimes there were patients last year who unfortunately had PCO2s of like 120, but their pH was actually okay and they were buffered and their bicarb was pretty high. So it ended up being okay, but it is like seeing that end tidal of 120, like you all had mentioned, and like, or like not seeing an end tidal because it's so high can be terrifying. And I remember having that experience myself. And so when these patients are in extremis, when their pH is in a spot where it's, below 7, bicarb can be helpful, but just remembering that bicarb in a patient who is not really breathing faster or breathing it off on their own can become carbonic acid, and then actually can become like dissociate and become hydrogen ions, can actually lead to worsening acidosis as well. So just like something to think about, but in extremis, it's definitely something that can be used. And then ultimately, I think the hardest part is that like a lot of times these patients really just take a lot of time. And so like giving them all of those therapies that we've already talked about and just kind of getting to that point where, they like giving them time for the steroids and bronchodilators to really take their course might just take a lot of time. So they really just do take time to improve. And then once they turn that corner, it's like amazing how fast you're able to wean your pressures, wean your support, and get them to a better spot. However, sometimes we also have like these complications that develop. So for our patient, they were in pressure control. You all had them in 35/10. However, they were satting 75%, even though they were on 100%. The heart rate was 170. SATs or blood pressure was 75/35. They were sedated on a ketamine drip and paralyzed, and weren't really aerating well. Again, not having any wheeze now. We're on continuous albuterol, had gone to turbolus already, had been on IV methylpred now, and were intubated, as I mentioned. The I time was 0.8 and our respiratory rate was 30. So when we see hypoxemia, do you all have any thoughts on kind of like what other concerns or like how you troubleshoot hypoxemia on someone who's already ventilated or intubated?
You could increase the eye time.
Yeah, exactly. Do you have other concerns about like what might be going on with the patient?
Is it pneumo?
A pneumo for sure.
On the albuterol, like, are you BQ mismatching with?
Yeah. BQ mismatching. So I think the biggest things to think about with hypoxemia is that like, are they not, are they under resuscitated? Do they not have enough like pulmonary blood flow and just like blood flow in general from poor perfusion? So do they need more resuscitation? Because sometimes a low SAT could just be because they're not actually perfusing enough. Worsening bronchospasm for sure can lead to hypoxemia as well. And then are they not on the appropriate vent setting? So like you said, do they need more eye time? Is it because they're actually hypercarbic and not ventilating appropriately, and your PCO2 is 130, that you are having hypoxemia? Definitely potential. And then the big thing to think about in these patients that we're like giving a lot of pressure to can be pneumothorax for sure. And air leak in general. Other kind of complications that we think about are in the setting of being on these high pressures and a high intrathoracic pressure is hypotension. And that can be because of the high pressures. It can also be if they have a pneumothorax, they can end up having or pneumomediastinum from all the pressure. Are they having tension pneumothorax physiology and really not able to fill their heart and causing issues from that perspective and poor perfusion from there? Or is this also like from beta agonists and the toxicity that we can have from that, which we definitely do see? The other thing, if you're seeing a lot of hypercarbia, that high vent settings is for similar reasons. Is there a pneumothorax that's not allowing you to properly ventilate, or is it, leading to tension physiology, worsening bronchospasms, and then just not being on the appropriate vent settings can also lead to these things as well. And so you all mentioned this very early on, but and kind of things that you can do for these patients in terms of tips and tricks, really thinking about that like bag and squeeze and like doing manual decompression and squeezing on exhalation can be really helpful. And sometimes I've seen that be more helpful than anything else we can do. And to really kind of help them force out the air that's leading, the air trapping that they're having. Other things we can do are putting albuterol down the tube. But, I think the biggest thing that to emphasize is, once these things are happening, we, usually it's when you holler and route to us, we would love to be part of that conversation. So making sure that we know, and more so that we can prepare the things that we need, and not just for the fellows, like our responsibility at that point is also to loop our attendings in and let them know and have a conversation, all of us together, about how we, help you all make sure the patient arrives here. And then the things that we can work on while we're waiting is talking to our anesthesia colleagues and our cardiovascular surgery colleagues in order to prepare for other things that we can do, like using inhaled anesthetic, isoflurane, or preparing for ECMO, because sometimes that is what the patients need, is just like lung rest until they're able to break that bronchospasm with like the steroids and the therapies that we're giving them. Do you all have any questions about that? Or anything else that you all have seen in your practice that you found to also be helpful in addition to kind of the things we've talked about so far?
Yeah. You draw down the tube, like how.
Do you do that just like straight, like, you like mist it in there somehow, or just like squirting it?
So when I've seen it done, I've seen it squirted down the tube, and like the respiratory therapists do it. But Michaela,
They just pour it down the tube and then you bag it in.
Oh, I'd try that. What dose do you bag down there?
So usually it's the vial of like 5 or 10 that they squirt down, and then some after usually put like a little bit of saline as well, and then bag it, but it's not pre-mixed before.
All right.
Like concentrated albuterol, in the same way you could do like epi down the ET tube, and it's usually like a
I
concentrated.
mean, we have the vial of it concentrated, that's why, how much do we want? Cause I mean, it's a big vial.
How much do you like TURB?
how much we like TURB?
Yeah,
Or
like,
just like,
how much, like, cause it kind of seems to vary, like some people really like TURB, some people could care less about it.
I think when you're up, like when you're in a spot where you're not moving any air, I think we love TURB, and that like, especially that's something that you all can do. I think sometimes, like a lot of the tachycardia or cardiovascular reasons are why we end up stopping it. But I think in an emergency setting, giving a bolus and starting it is great. I think it's a great idea when you're kind of in a tough spot. Michaela, do you have thoughts?
No, I completely agree. I mean, if the only time I don't like TURB is if you already have beta agonist toxicity, then it's like, but at that point I'm thinking, if you're getting your albuterol to your system, that means you should be moving air. And so then it's more like, okay, do we have the full picture here, more than whether like TURB or not?
Sometimes you see us stop it as soon as they get here, and that's not because we didn't like, they definitely needed it en route, but we have some other agents that like aminophylline that may not cause that tachycardia or beta, agonist toxicity. But I think in the moment, it's like, we need to do whatever we can to get some ventilation.
And then another question, so we get this a lot on intake. Say they've given pre-loan initially when they walk in the door, because that's what the nurse, triggered in the pathway, and it seems like they're definitely going to need ICU care, but they've got the pre-loan 3 hours ago. When do you guys like to just go ahead and tell them dose with salumedrol, or like what are your thoughts on that?
I mean, in my practice, I honestly, what did you say pre-load? Did you say like prednisolone? Oh, gotcha. Helone. I honestly just say go ahead and start the IV methylpred. Even if they've gotten a dose, especially because it just works a little bit faster just in terms of being IV versus enteral. And so you just know that it's getting into them a little bit faster. I don't think I worry about like overdosing them or things like that I think the risks of those are so low that if you're really that worried, giving a 2 per kilo dose of methylpred, I would just tell them to kind of go ahead and give it.
Cool.
And I would agree, because I'll tell you, even amongst the PICU attendings right now, there's great discrepancy about what max dosing is. So there's pharmacy-led max dosing that you'll find on Lexicon. And then there's like Mike Bell, who will be like, yeah, don't care if the patient's 120 kilos, do 1 per kg Q4.
Wow.
So you may have some discrepancy with like how much steroids, but definitely going to IVs, it would probably be more universal than the actual dose.
Question about the PEEP debate that you talked about earlier.
Yeah.
So say that we do PEEP trials and what ends up working for the patient is a really high PEEP. Say that we land on like 14 or something high, but it works for the patient. That will be supported in the PICU?
Yeah, I mean, I
When
think
we
the biggest thing, and I always appreciate it all, because like, I think you got to do what you can do to get the patient to us like in one piece, which is, I can't begin to imagine like how scary that is, especially with these patients. And so if that's what they need, like, and you're watching all of the things, like you said, like, are you getting better aeration with that? Are you having decent chest rise? Yeah, PEEP of 14 is a lot, but if that's what you're needing in order to, well, you know, with a low rate and that kind of eye time, low relative eye time, or like, you know, what we're saying, like a eye time of 1, but like you're doing all the other things and the PEEP being a little bit higher is what they need, then that's what you got to do for them. 14 is a little bit on the higher side, but that being said, if that's what they need, that's what they need. And then we can kind of, you know, our event is just able, the servo that we have is just able to give us a little bit more feedback that we can make those adjustments when they get here. But as long as you know, you do what you need to do to get them here, I think I can't fault you for that.
Okay.
I agree. The only thing I would add is, when we are on high peaks, now that Danny has shown me that polls can be done on the travel band, which is so cool. I think that would probably be a point where I would ask you, like, hey, that sounds good. Let me know where your plateau is, so that we are kind of on the same page of like where we are in terms of pressure to the lung. That would probably be my only question.
We were just asking, like, with our ventilator specifically, to do the plateau pressure, don't we have to be in volume? So we have to switch them to volume, check the plateau, and then could go back into pressure. Would we want to be in pressure for checking? I know, that's, I'm just thinking of how.
The practicality.
Yeah, the practicality of how hard or easy it is for us to check all these things with the transport ventilator.
Yeah, so that's where, we're just having some conversation in the room, Guy 3, and I showed Michaela earlier that we can do an inspiratory hold on the transport ventilator that we have, but that can only be done in volume control. We're in a pressure control mode, PRVC or pressure control. You can only do an expiratory hold to measure an auto peak, as opposed to an inspiratory hold to measure the plateau pressure. So there is some discussion that we might have with like respiratory, and we meet with Dr. Basu about once a month, just to discuss critical care practice issues in terms of developing like an asthma event protocol for what mode do we want to choose for people to try and utilize in order to like effectively ventilate patients. Because BRDC as a mixed mode on our event doesn't always give you all the things that you want to do compared to doing volume control and then being able to measure like a plateau pressure like the attendings would want in the PICU, if that was kind of a universal sort of metric that they're looking for to determine like how we're titrating PEEP or things like that in some of these sicker vented patients.
And based on what we were saying earlier, we probably want to be in a pressure and delivering the oxygen for this patient.
That's the problem.
I will say, like at certain other institutions, they actually have the same issue of, not issue, but like the inspiratory hold can only be done like based on like the Draeger vent. From my understanding, like typically you have to be in volume control to be able to kind of get that information as well. And ultimately, like I think it's up to like keeping the patient safe and like doing what you are comfortable with and like not, you know, you don't have to just like switch over if you don't feel comfortable with that, to be able to get that information. I think at the end of the day, doing what is, you know, you're comfortable with is the most important thing. But in theory, volume control should also be fine for a short amount of time, or even a long amount of time. Like there is nothing wrong with using volume control for these patients, especially if you want, like you feel comfortable with it and are able to get that information.
Is that something like could consider, would we be able to easier ventilate them on the Hamilton?
Yeah, I mean, if you know, the challenge is that sometimes we're going out as like a Charlie team for like sick asthma patient to like start BiPAP or something like that, or they're not that sick when they first present, or we don't have a complete picture and send the team out and then sort of don't know kind of as we're going on.
I was saying if we did know, like if they're threatening to.
Yeah, absolutely. You can always ask for respiratory grab. Sure.
I just don't know the modes, like I don't know the things you can check like as well on the Hamilton, so I do.
Same things.
The only other thing, this is like kind of a random little, I also think about is the fluids that we choose to use in these patients. If you have any ability to do so, lactated ringers can just be a little bit better of a fluid choice than normal saline if you have that available, just because a lot of times these patients run into having really high chlorides because we do give them a lot of boluses, we do a lot of resuscitation, and then they end up having like a metabolic acidosis from high chloride. And then that is something that we're chasing also when it comes to like our ventilation strategies as well. So if there's any way to do lactated ringers, even though there, you know, it has the word lactate in it, it's quite low, and I actually we don't worry too much about that. It can just be helpful when we choose fluids for our resuscitation and like the fluids that we put them on. And a lot of times we end up taking out the dextrose from it just because you're on steroids, you're going to become hyperglycemic. A lot of these patients ultimately get started on an insulin drip as well. And so, you know, just doing regular lactated ringers without dextrose can be helpful.
So LR with potassium?
LR has some potassium in it in the first place. And so I think for when you are transporting, just doing lactated ringers by itself can be fine. And that's usually like the stock bag that we have, but it doesn't hurt to, sometimes people do add LR plus 20 of K.
Thanks,
Thank
guys.
you so much. Please let us know if you have any other questions.
Will do. Thank you guys so much.
Thank
Really
you.
appreciate it.